Everybody, welcome to this EFIC webinar on chronic primary pain. My name is Mary O'Keefe. I'm the Research Projects Advisor at EFIC. And before we kick into the topic, I just want to give you some information for people that are newcomers to EFIC. So who we are. So we're a multidisciplinary professional association, professional organization in Europe that represents the field of pain medicine and research. We're made up of 38 European chapters of IASP. And we represent physicians, basic researchers, nurses, physiotherapists, psychologists, and lots of health professionals across Europe. So if you want to find more information, go onto our website, www.efic.org. We also host the largest pain education platform in Europe. It's called the EFIC Academy. We have lots of education tracks for physiotherapists, doctors, psychologists, and nurses. So be sure to check that out to keep up to date with their most latest research. And finally, just to signpost you to our Congress. So the EFIC Congress will be on the 20th to the 22nd of September in Budapest. And the theme this year is personalized pain management. We'll have excellent researchers and clinicians. So if interested in coming along, please go on to the website. So now we're ready to get on to the topic. So we're delighted to be joined by three fantastic experts in this area that know everything about chronic primary pain and will be able to answer all of your questions. So we're joined by Professors Rolf-Detlef-Treede from Germany, Beatrice Kowisi from Germany, and Paul Cameron, who's the EFIC Advocacy Committee Chair from the UK. So on your screen, you will see there's ability for you all to ask questions in the Q&A function. Please make use of this because, as I say, we have the best experts here on this webinar and they will be able to answer anything you ask. So I'm just going to start off with a definition of chronic primary pain. So this term has been implemented in the recent International Classification of Diseases, ICD-11. It is defined as pain in one or more body systems and in any body site or in a combination of body sites. And the three key factors in the definition are it has to be pain that persists or recurs for longer than 3 months. It must be associated with significant emotional distress or significant functional disability. And finally, the symptoms are not better accounted for by another diagnosis. So in this classification, chronic pain is the dominant clinical problem and is considered the condition in its own right. So that's my introduction over, and we can get into the questions. So Melinda, you can finish sharing your screen if you want. Okay, so I can kick off the questions. So the first question for you all is, why was this term created? So chronic primary pain, who thought of it? Why do we need it?
Maybe I can start because I was involved in the process that led to introducing this. We had been inspired by the headache field, where many years ago, the definition of primary headaches versus secondary headaches had been a really game changer. And as you are all aware of, migraine is the model disease that is a primary headache. It's a little bit more difficult with the chronic tension type, and then the two other forms. But this classification has finally been adopted around the world, and therefore neurologists among the IASP people had always encouraged the pain specialists to try to come up with a similar classification to try to change the field. And therefore, we took the term chronic primary pain versus chronic secondary pains, with the idea being that chronic secondary pains are what everybody thinks about pain as a symptom of something. And if that disease condition, like an osteoarthritis, is chronic, then maybe the pain could also be chronic. However, on the other hand, researchers, clinicians, overall patients have recognized that sometimes really pain is the disease. And as Mary mentioned, this is for conditions where pain is the leading complaint with a number of other conditions. And therefore, the term chronic primary pain is supposed to indicate instances where basically pain is the disease. And then both types of chronic pain need dedicated management.
Okay, great. So thank you to the attendees. You've already started asking questions, so we'll get into those. So the first question, I cannot see how ICBPS fits into this definition. Why is it included? Thank you, Jane. Does anybody want
This
to
is
answer
Jane.
this?
Okay, then maybe I should also take it because Jane, thank you for joining us. And we have discussed this in the context of a EU-funded project that has just come to an end. I'm much less an expert on bladder pain syndrome or pelvic pain syndromes than Jane is. So I relied on the experts that we had. So the classification that is now part of the ICD-11 had been created by a team where we had usually pairs of experts for each topic. So we had visceral pain experts, and the visceral pain experts indicated to us that there are a few conditions that would qualify as something like a chronic primary pain condition, which means where pain is the leading complaint. And this abbreviation that you see, bladder pain syndrome, I think to people who don't know what that is, sounds like it's qualifying. It's a pain syndrome that is basically considered to arise from the bladder, but without any bladder pathology. In each case where there is a bladder pathology, it automatically becomes a chronic secondary pelvic pain condition from the bladder, and in the classification, there's a place for it. So for any individual who has pelvic pain condition, the important service that the classification provides is no matter what, there's a landing place where this condition can be classified. Now, IC is a more tricky term. So I was told by our experts that interstitial cystitis is a misnomer. There is no inflammatory process between the proper cells of the bladder epithelium. And it would only, and this term would be used for those patients who don't have a pathology in the bladder. So the term itself implies a pathology. And if a Hana lesion or something like that is found, that I was recently made aware that there are some things that can be diagnosed, then this would automatically become a chronic secondary pain condition. The other thing that I think is important here is very often patients have more than one problem. In the case of bladder pain, a second problem which seems to be as bad is urgency. Actually, I just came for the inauguration of a center for artificial intelligence in psychiatry, and they had drinks, but I had to look for the toilet. So I can sympathize very much with the topic of urgency. So if a non-pain complaint is the leading complaint, then there may be other conditions in the classification that would be the primary diagnosis. So chronic primary pain is for patients who have pain as a leading complaint, and it cannot be assigned to a pathology in the organ where this pain would be perceived. It's a little bit complicated, but maybe that's roughly what one would say. Well, Jane is promoting the issue of pathology in the bladder. So for Jane's questions, whenever this pathology is demonstrable, it would be delegated to chronic secondary pain, because then we have, if that explains the condition. So it's not carved in stone. The diagnostic process for individuals affected with a disease condition have not been fully developed. So the classification has definitions, and maybe Bea wants to add a little bit to this. But clearly, diagnostic algorithms need to be developed and need to take these different things into account.
Bea, would you like to say something?
Yeah, I can continue. So to classify the chronic pain, we developed a classification algorithm that guides through the chronic pain diagnostic criteria. Of course, that does not guide us through criteria when to perform what kind of diagnostics. Chronic primary pain points out that the pain is the leading problem. It's a disease in its own right. But of course, when the clinician thinks there are red flags that an underlying condition could be there, it's the clinical judgment that guides you as to whether you follow up or not. And of course, when there's a red flag, you probably should follow up on that. We now have this diagnosis of chronic primary pain, which is not a diagnosis of exclusion. It has positive diagnostic criteria. So you don't have to exclude everything that there is, and the treatment target should be the pain. So it might help to avoid all these iatrogenic factors, but there's no we can't give a rule as to when to perform what diagnostics. It's the judgment. But the new classification and the new diagnosis give a framework for all the research that now has to follow if there can be clear guidelines. So it's a new diagnosis, and it's also a framework for everything that comes next.
So we have a number of questions here, but I'm going to flip the order of them to just keep us on this topic. So Jane's question, did you involve patients in this classification process? Or did others involve patients in the classification process?
The development of the classification was not in cooperation with patient organizations with respect to finding the wording. However, from the very beginning, through EFIC's connection with Pain Alliance Europe, we actually had been discussing this at events called Societal Impact of Pain, which are annual events where we have the European Pain Societies and also the different patient organizations present. And actually drafts of the classification had been promoted in newsletters of several of these patient organizations. So mind you, this was 10 years ago. So the patient role at that point in time was a little bit more passive than it would be nowadays, but clearly the information was spread. And quite clearly, patient organizations, in particular in the field of fibromyalgia, were very interested in getting into this dialogue. Having said that, I was happy to see that Jane Meiling asked the first question, because here we have a good example where the current discussion or a current discussion on how this classification would evolve is actually driven by a patient representative, namely Jane. And we had one video meeting on this topic with representatives from Asia, North America, and Europe, noticing that in these three parts of the world, the concepts of the clinicians are slightly different. And we will continue this process. And there are many other topics. So clearly, looking forward, there definitely is a role for patients to mention the things that come to their mind. And the way this is handled by WHO, this is an important point. The classification is owned by WHO now. And since the beginning of last year, we're in the maintenance phase. And for the maintenance, there's a proposal platform. And proposals can be made, and they are evaluated for two things: scientific evidence and consensus by all stakeholders. So international, but definitely stakeholders nowadays should include patient organizations. So looking forward, if there's fine-tuning needed, then the proposal platform, which is public, of WHO is the place to submit the proposal, and then dialogue will be initiated. And I'm grateful to Jane in particular to have started this around bladder pain syndrome. Irritable bowel syndrome is another topic where we are not as actively discussing, but I personally think that the topics that we have to address are very similar. And this is version 1 of a pain classification in ICD-11. Headache classification a few years ago was version 3. So certainly there are things that can be improved.
I have one question following on from Jane's comment about patient involvement is, do we have any evidence at the moment, I mean, any piloting of the term chronic primary pain to get any sense of what is happening at the moment? Has it improved management? How have patients reacted to it? Do we know anything about that at the moment, about the actual implementation?
I think Bea has many answers for that.
Yes, I'd love to answer that question.
Great.
We conducted a study that asked patients with chronic pain what they think of the new diagnosis. It has not been published yet, but it will be submitted very, very soon. And the results were really promising. So, of course, the diagnoses are new and they are not in the healthcare system yet in the countries in Europe. So first I introduced the patients and participants to the concepts, to the main diagnoses. What is chronic primary pain? What is chronic cancer-related pain? What is chronic secondary visceral pain? And so on, with a brief video, and it was translated in scripts in different languages. The participants came mostly from Europe. We had many from Germany, UK, Norway, but also worldwide. So really global sample. And then we asked, what do you think? Does it represent your pain? Does it fit to your chronic pain that you are experiencing? Does it fit better than the diagnosis that you got from your doctor with the current system, be it ICD-10 or ICPC or textual diagnoses? And the patients indicated that the new diagnoses, and especially the chronic primary pain diagnosis, fits well. It has the potential to reduce stigma. It makes it easier, or will make it easier, to communicate the pain to family members, to doctors. But of course, that's what they expect. It's not the status quo what there is, because the diagnoses still have to arrive in the healthcare systems. And then we will see how does it work when they are actually in interaction with the doctors and the new diagnoses are communicated.
And
maybe I should add,
yeah.
this date, January 2022, does not mean any healthcare system is using it. It was the first day from when on mortality data can be reported via the new system, and there's a 5-year transition period, and they're basically software changes. Iris and Doris, I think, are the names of the softwares which are kind of competing, which one is doing what. So slowly countries are switching to reporting death, but not morbidity rates yet. And then there are some countries that don't have a very elaborate health information system that have started to implement this new system. What comes to my mind is Kuwait, Rwanda, and more recently, actually, Israel. But there have been some analyses that compare the old and the new system in retrospective data. And maybe, Bea, you want to comment on Thailand. I think our Thai colleagues were really very advanced to analyze what effects it could have been if it would have been implemented in Thailand.
Yeah, so they had a look at their database, 1 year of all the inpatients with chronic pain, and then they did a similar analysis with 1 year all outpatients who came to the clinic. And what they found is that the new diagnoses, all the 7 main categories, chronic primary pain and the 6 chronic secondary pain categories, they capture a lot of the diagnoses that previously went as unspecified chronic pain, other chronic pain. There was this R code in ICD-10. So it really makes the pain visible, it shows the pain. And not many diagnoses were in the ICD-11 unspecified category. So it showed that they can be assigned to specific diagnoses, which in turn can impact treatment choices, because now we have a pain diagnosis. This is good to get pain treatment. It's difficult to get pain treatment when you don't have a pain diagnosis. And in some countries, it's even an exclusion. So if you don't have a pain diagnosis, you don't have access at all to pain management.
I think it's fair to say, Mary, that it's going to be some years before we can get population level data against these, in part because, as already been mentioned, the systems are different across countries, and some countries don't use them at all, or very rarely, other than outside, particularly outside research. In the NHS is a perfect example of lack of coding for the ICD. Yet it's a very comprehensive health system, but in a comprehensive digital system now, but not commonly used in terms of ICD-11 because of the various different things that happen behind the ICD-11. So, you know, I think studies and research studies will be useful, but that will be at an epidemiological population level rather than a clinical level.
Maybe if I can expand on that. So there has been a question earlier about the 3-month criterion, and
I was just about
you
to
mentioned
ask that.
research versus clinical applications. So the 3-month cutoff is for the research definition, and this again was inspired by the headache field. So migraine is only migraine between 3 and 72 hours. If it lasts shorter, it's not migraine, and if it lasts longer, it's not migraine. And this is how it was used in all the clinical studies. In clinical practice, however, if it looks like migraine, it lasts longer, then you nonetheless try to treat it like migraine. So this is I think it's very important to keep in mind that some of the definitions are intended to have a better research base, have clear data published so that we can then see which management and self-management for that matter is appropriate for who. So the 3 months are strict. So clearly after 3 months, it is pretty much chronic. in the post-surgical field, there's evidence that you can predict chronicity much earlier. But in discussion with people from the field, they agreed to have this as a uniform criterion for all types of chronic pain. And it was also harmonized with the definitions for chronic headaches. So chronic headaches, chronic pain have a 3-month criterion with a certain percentage of days. If it's episodic chronic pains, that's also accommodated here. And the strictness of the definition is for research purposes, so that future studies can have a clearer identification of the patient groups. For clinical practice, of course, you try to find the closest fit and an available management for which you think there's evidence that it works.
So what would the advice be to a clinician at the moment that is maybe trying to implement these definitions, whether it be chronic primary pain, chronic secondary pain? If the pain is for 2 months, how does that person decide how to categorize this or is this an evolving area?
Well, I think the simpler answer is, I'm taking the post-surgical field here as an example, which seems to have the best evidence that chronicity can appear quite early, and also where this alternative definition, pain persisting beyond normal healing, can actually be operationalized. And here, I think the prudent way to do things would be if, as a treating physician or as a person involved, and you think you are getting something chronic after a surgical intervention after 2 months, don't wait another month. Yeah.
Okay. Yep.
But if you're going to be included into a study, you have to wait another month. And if the treatment wasn't successful by then, you might then be included in the study. So that would be the difference.
Okay. Thank you. So we have a question here. What do you see as the difference between chronic primary pain and nociplastic pain?
That's a very hot debate. So historically, at about the same time that we started to develop a classification for WHO, which then fortunately became implemented by the vote in 2019, there was another group at ISP spearheaded by Eva Kosek, and Winfried actually participated in both groups, that was trying to come up with a mechanistic descriptor for fibromyalgia in a way. The background was that neuropathic pain had been a new term pretty much around the turn of the century. It was invented. A special interest group on neuropathic pain for ISP was founded in 2001, 2002, and started to become active. And this group pointed out that when you talk about neuropathic, there must be a clear-cut relationship to the part of the nervous system that is involved in pain, which is the somatosensory system. And with that, we have received a clear-cut neurological definition of neuropathic pain that's also transferred into the classification. But people suffering from or being advocates for fibromyalgia patients were a little bit astonished or irritated for a while, because they thought fibromyalgia would be a neuropathic pain. And if you call everything neuropathic, that is something funny. And I've heard some other terms like functional pain disorder. These were kind of excuses when you don't know what it is. And initially, neuropathic pain was something like that. And when it became clearly defined what it is, and that is different from nociceptive pain, where something starts in the periphery, let's say with an inflammatory process, there was a group trying to come up with a term that is a mechanistic term for diseases like fibromyalgia. And this process is still ongoing and is quite controversial. So the first paper was out or came out during the time that we finished the classification. So we indeed quoted the first paper by Eva Kosek's group in our paper on chronic primary pain. So one thought is that this third mechanistic descriptor might be a positive identification criteria set for patients with chronic primary pain. Now, this has never been claimed completely. And there's a lot of literature now to find nosoplastic pain in everybody. There is a grading system for nosoplasticity that has been published in 2021, which I think is good to have, because then you can try to check it. But this grading system is not verified. As a matter of fact, we have submitted a paper where in our data set of patients with fibromyalgia, complex regional pain syndrome, nerve injury, and osteoarthritis, this grading system did not work. So before it's good to have it published so it can be tested. And I've heard that in other labs also this grading system has failed. So it's good to move forward in the process, but so far we do not have a set of criteria to identify a third set of mechanisms, and some authors even question whether that exists. So they are related. So it's good thinking to think that nosoplastic mechanisms, if they exist, might play a major role in chronic primary pain, but maybe this set of mechanism is so generic that it applies to everybody. And then it does not distinguish anything. So this is ongoing discussion. And please, if you want to contribute, do so based on data. And patient reports are data, yeah, just to remember that.
So we have a question. What connection is known at the moment between chronic primary pain and intestinal dysfunction disease?
Bea, do you have an update? We had discussed this early on, not recently.
Yeah, I think the last time we discussed that, the consensus were that we don't know much yet because we don't have much data on that.
Yeah.
And we need more research done. And as far as I'm aware, that's still up to date, that we need more research done to answer that question. So maybe when there's this webinar again in a couple of years, maybe then we have a good answer if there are more studies. So
yeah,
it's a field of study.
So I think
I'll just
Paul, yeah,
probably worthwhile just reminding ourselves that this is a step in the right direction, but it's not the end of the journey. I think. I mean, that's the coding. It was a lot of work. It's a huge step forward to try to start classifying something which before was out in the ether, and people were doing very, very different things, and we're trying to get things together with evidence. But this isn't, as Rolf alluded to earlier, this isn't the end of the journey. It took 10 years to get to this point. It's going to take another 10 years to get to another point that we will be happier with, and it will continue as evidence progresses. So I don't think we're going to have the answer to every single question, and there may be unintended consequences as well, but we'll address them as they come, I think, as much as we can.
Yeah. There was a related question about functional pain disorders, and there is this diagnosis of somatoform disorder or something like that. We had some exchange with the psychosomatic medicine field that is championing this type of diagnosis. And our proposal had been, if pain is the leading complaint, we would recommend to call it by the name of the chronic primary pain condition and treat the other symptoms and signs as comorbidities that also need attention. And if it's the other way around, then also do it the other way around, then use the other diagnosis and make sure that you manage the pain. Then this question, does pain management distract from somatic factors? I think I would phrase it differently. If there are some somatic factors around, it doesn't mean the pain goes away when you treat those somatic factors. And it doesn't even mean that they are the leading mechanisms. There are built into our bodies mechanisms that our nervous system is highly plastic and responds to any chronic challenge. So a lot of plasticity is going on all the time. So actually, 4 weeks ago, I injured myself when cooking, and initially my whole little finger was painful, and then it finally focused on where the cut was. And this is reflecting central sensitization that usually is transient, but it happens all the time. And therefore, a lot of plastic changes can be ongoing. And I think it's very important that we have a mechanism to flag whenever pain is a problem that needs attention. This is primarily the purpose of the chronic secondary pain diagnoses. We have built in a severity scale. So mild maybe it's flagged, but doesn't need specific management, but if it's moderate to severe, then clearly attention should also be paid to manage the pain because it doesn't go away automatically. In the field of musculoskeletal pain, I think there has been good experience that to manage the pain does not distract from somatic factors because red flags have been identified that are always asked about. In the visceral pain field, I think it's less developed yet, as Paul has been pointing out. And therefore, I think what needs to be developed is red flags for pelvic pains, for abdominal pains, GI system pains, chest pains, and so further and so on. And this part is definitely not as advanced as the musculoskeletal pain field. But if you want to have some inspiration, look at musculoskeletal field. And as a matter of fact, WHO itself is finishing its own guideline on chronic primary low back pain. It was supposed to come out second quarter this year. I heard it was a little bit delayed, but I assume that by the end of this year, definitely there will also be a WHO guideline on that. But you may have national guidelines on what used to be called non-specific low back pain and would now be called primary low back pain, where you can see how this is handled with red flags. So nothing is perfect, but I think that's a very reasonable approach.
I just want to add to another question that came in from Jane about the emphasis on the pain aspect, distracting attention from other aspects. So I remember seeing an editorial in response in pain. It was taking is a pain-centered view of the world too narrow? What do you remember that editorial, and what was your overall view on that point? Because I think it resonates with Jane's comment.
Yeah, I think I tried to answer this point. Maybe Bea, you have additional comments?
Yeah, I think you did focus on that. So the question is, what is the main complaint? And is it the pain, as Rolf-Detlef mentioned earlier, or is it the other symptoms and pain is just one of them? And of course, even if it's the pain at first and you treat the pain and there's still other symptoms going on and they don't get better, you should have a look at that. And you should evaluate with the patient, okay, what do you need? Is it the pain management or is there something else that you need? Because now the other symptoms are the focus. So the treatment focus might change during time.
Yeah, definitely it should not distract at all. And if in certain conditions there is a bodily component, let's take musculoskeletal field again. So the exercise programs, in addition to non-specific beneficial effects of exercise generally, they usually have the aim of strengthening part of the muscles. So clearly in the musculoskeletal field, even in the so-called primary conditions, there is a certain therapeutic attention paid to the musculoskeletal system. And by analogy, I would suggest that in the visceral pains, the same should be done. So if urgency is a problem, there needs to be some management for that. If diarrhea is a problem or constipation, something that must be done about that. And if shortness of breath is a problem, whatever. So I think mutatis mutandis, one could follow also the multimodal approaches to management, which usually have a condition-specific component. There are some overall generic aspects, but usually they have condition-specific components. And I would personally like to emphasize it's not one size fits all, but these condition-specific components must be in there. And then the next step is individualized management.
Okay, that was very helpful. That was really clear. Thank you. So the next question, is cancer pain or pain after cancer treatment included in chronic primary pain or secondary pain?
Clear answer, Bea.
Yeah, so we mentioned earlier there are 6 categories of chronic secondary pain, and one of these actually is chronic cancer-related pain. And then on the next level, it can be distinguished whether it's chronic cancer pain, so directly associated with the active cancer, tumor, and metastasis, or if it's chronic pain after cancer treatment, so after radiotherapy or after chemo, or hormonal or any other therapy.
Maybe one addition. So we didn't discuss it initially with respect to cancer, but with respect to rheumatoid arthritis. So the clinical experience is that with the biologicals, the inflammatory markers go down very quickly. but the pain doesn't go down as quickly. And in discussions at the rheumatology meetings, the consensus was that this does not change the diagnosis. It's still the same thing, the same patient, the same diagnosis. However, if at some point the rheumatologist says, I can't do anything more, then with the same diagnosis, a person could then be moved on to a pain specialist. And this applies to cancer as well. Of course, treating the cancer is important. Fortunately, more people survive their cancers. No oncological treatment needed at all. But as soon as they have a painful condition that requires attention, they should receive the additional code, chronic secondary pain due to cancer or its treatment. And then the pain specialist would come in addition. And if everything goes well, nobody has to treat these people. But if they are unlucky, they may require some ongoing management of their pain, although their cancer has been treated. And an interesting aside is that from this year on, all cancer diagnoses in ICD-11 carry the question, is there chronic pain with it? Does it have a manifestation of chronic pain? And it does not become primary by the primary disease being treated. That's a very, very important question. Thank you very much for asking that question. And this is, as I pointed out, for the patient journey, it's very important. As soon as pain becomes a problem, they should be alerted to it. And by the way, this is not palliative care. So at MD Anderson, they have a palliative team that treats patients around that treatment, and maybe at end of life if necessary. And in between, they have a chronic pain group that does a totally different treatment. They withdraw all the opiates for the first thing, whereas acutely and also at end of life, there's a good place and indication for opiates. So very important question. It remains a chronic secondary pain as long as it can be ascribed to an initiating event, and then the pain needs to be managed and self-managed when it's there.
There's a few questions around terminology and is one term better than another? So there's a question about functional pain, which Rolf-Detlef, you referred to.
Yeah, I mentioned
earlier.
that. Yeah.
Yeah.
Functional pain should be deleted as a word. I'm not quite sure whether I've succeeded to do so the way it is done. It would still be searchable in the ICD-11 coding tool, but you would be directed to the primary pain codes. So I invite everybody to, if you're interested in how WHO codes things, just type in ICD-11 and WHO, and it's freely available to anybody. And the coding tool and search functions are pretty good. So they're not quite as good as Google yet, but you can type in your favorite word, and very likely you are directed to the wording that is in the system. So I haven't tried it for functional pain, but it would be an interesting exercise. If somebody can do it on the side, try what happens if you search functional pain in the ICD-11, and you might be ending up at two different codes. One would be somatoform disorders, and the other could be primary pains. Or you get nowhere. I have no idea. I haven't checked it.
What would you say to a clinician that likes using that term, functional pain, that feels that changing their terminology might feel unnecessary? What are the key arguments against it, in your view, against that term?
Well, one argument is that it has not been helpful, because usually it's an excuse. If a clinician uses functional pain, if you ask them which function is altered, they're at a loss and say, well, it's a function of pain. So the term chronic primary pain is much clearer. Again, the analogy, chronic primary headaches, it's not the symptom or something going on in your head, bleeding or something else. The headache is the disease. So chronic primary pain is the disease. And the term functional pain was intended to kind of suggest it might be the disease, and people didn't dare to say so. So the recommendation for a clinician would start calling it chronic primary pain. And some feedback we received from patients is that this would carry less stigma, because there's primary hypertension. Yeah? So take hypertension. In most cases, 98% is nobody knows where it's coming from. Yeah. And it doesn't carry the stigma that people are making it up. The doctors don't make it up in Scotland to get more money, although one might suspect so, because your payment depends on how many people you treat for hypertension. Yeah. Sorry for that.
I think the other thing, Mary, is that it's an evolution, isn't it? Because, you know, I think there's a question that was mentioned earlier on, I think somewhere on about how GPs might view the new terminology.
Yeah, I was just about to ask that. Yeah, so please, you can answer that now. Yeah.
Again, of course, it might be different across different countries, but you know, I mean, my personal experience is it's difficult to get them to change anything, and it's often based on their own personal interest in a disease area, for example, as to how much interest they take at all, because they're doing the daily do of looking after people and doing the best for people when they come into them. So they're not overly concerned. So there's many out there that still talk about reflex sympathetic dystrophy instead of complex regional pain syndrome, for example. And I imagine it will be difficult to get them to accept new coding, and part of that motivation will be depending on the systems that we talked about earlier as to how important it is that they learn the new codes.
Yeah. So the person who asked the question mentioned ICPC, the International Classification of Primary Repair, which is an old one. And there's an ongoing debate whether there's any need for a new one, or whether it would rather be a subset of the classification of diseases. And as a matter of fact, this subset already exists on the WHO page. I was surprised to see it a few months ago. It's called the primary care linearization, which is a subset of the entire classification set. And there are some pain codes in there. I haven't had time to evaluate them, but maybe Paul, you and some other Scottish primary care specialists can have a look at the primary care linearization. It did not exactly follow the paper by Blair Smith, but it doesn't look completely bad either. So clearly for primary repair, there already is a coding tool available on the WHO website. However, between Wonka and WHO, the last time I asked, they were still discussing whether they would discontinue ICPC as a separate system and whether the primary care linearization is the exact successor. This convergent, I think, is still ongoing, but hopefully it will actually be converging.
And just to add to the Scottish component there, so Blair and I and Leslie Colvin and others developed a core minimum data set, and within that we put the ICD-11 coding.
Yeah.
But it became very clear that it's very easy to collect or change the collection of data within a pain specialist clinic. But it's much more difficult to get that translated into GP practice at a primary care level. So that work is ongoing, but it will be a bit of an uphill climb to start with.
Yeah, as it is with implementing any new system. So yeah, the fact that this is evolving is a big point. So there's a question here about sciatica. So sciatica is a disease with its primary complaint being pain for most patients. Is pain associated with sciatica a chronic primary pain, or is it secondary one due to a neurological related problem?
No, it's definitely a neuropathic pain. It's one of the prime examples of a neuropathic pain, in this case of root affection origin. And therefore, since neuropathic pain is one of the 6 secondary chronic secondary pain condition sets that Bea had mentioned, it definitely is not, most definitely. Yeah, so that was a good question. I think the phrasing of the question underlines why one would think of it maybe, but it fulfills, it's a chronic pain due to, in this case, even a lesion that affects the somatosensory nervous system. And you can pinpoint exactly where that lesion is. Sometimes it's surgically confirmed, sometimes radiographically, but actually by the distribution of pain, you can do it clinically. And physiotherapists have some manipulations where they can verify with provocation tests whether actually due to this nerve affection. So you don't need any imaging, you don't need surgery to confirm that the sciatica is a clear-cut neuropathic pain condition. So it would qualify for definite neuropathic pain, because usually there are some sensory signs in the painful region, usually deficits, and you can pinpoint where the lesion is. So that would be definite neuropathic pain.
Okay, so we have a question here. Could you elaborate a bit on the definition of significant functional and emotional distress in order to receive the diagnosis of chronic primary pain? Where will this leave patients, coding-wise, seeking their doctor with a pain of a duration above 3 months that does cause distress, but not significant emotional and functional interference in their lives? That's a very interesting question. Thank you.
Yeah, that's a difficult one, Bea. In talking to Antonia, did you come up with good answers? Else
Yeah.
we have to improvise a bit.
So I think it's really safe to say that at the point when the patient seeks treatment for a pain, they usually do have distress and interference in their lives, because if not, they probably wouldn't come see you, especially when you're in specialty care. So the emotional distress, it does not have to be a clinical depression, but depressed mood, worries, anger because of the pain, that also is emotional distress. And when the patient says, I don't feel good because I have pain, it's like in our algorithm, we say there is a cutoff because we have to give advice like, is the criteria met or not? But again, earlier research was practice, it's your clinical judgment. If the patient really comes and there's pain, but there's no distress whatsoever, there's no disability or interference whatsoever, the pain would still be chronic. So we have a residual category of chronic pain unspecified that might apply, but in my experience, I have not seen a patient that would have been moved there because of a lack of distress or interference. Like, again, it does not have to be a mental health diagnosis. That's not at all what we mean. It's the distress, depressed mood or low mood, anxiety, that the pain progresses, that it won't get better, can be very, can also have a cognitive component like ruminations of the pain avoidance, fear avoidance, or at the other hand, enduring the pain, going over your limits, and then being stressed. That all qualifies as the distress and the disability.
Yeah, my comment is not directly to the point, but an important concept that we've implemented is that of pain severity, which is not the same as pain intensity. And you may have read papers that criticize to focus too much on pain intensity, because pain intensity alone is not the only important thing. And what we have implemented is a three-dimensional severity concept, which has intensity as part of it, but also distress and interference, as Bea pointed out. So from that perspective, and again, mild, moderate, severe is the very coarse grading that we're recommending, with the idea that if it's mild on all dimensions, probably moderate self-management will be enough. But as soon as it becomes moderate on any of the dimensions, some help, assistance might be needed. Yeah. I don't know whether that answers the question completely.
I think what we could add to that, what you just said about the chronic pain severity, is that, of course, we have the distress or interference criterion in chronic primary pain. So we have to assess it, is it present or not? But of course, distress and disability also play a crucial role in most chronic secondary pain conditions.
Yes.
So there we can use what the WHO calls extension codes to make it visible. We can also use the extension codes for the chronic primary pain. So when you go to the ICD-11, there's a box for each of the diagnoses that asks you to assess all these three dimensions that Rolf-Detlef just mentioned: the intensity of the pain, the distress due to the pain, and the interference due to pain, and then makes it visible also on the coding level. So it's optional, you don't have to do that. I imagine that maybe in a GP practice there's not time for that, but you can do that. And especially in chronic pain management and in research settings, it's really important to have that for all chronic pain, primary and secondary.
Yeah, and there has been a study from Marburg in High as first author. I'm not quite sure whether that's out yet, that compared just categorical ratings of distress and interference with some validated questionnaires. And there's a high correlation between the two. Where that would put people with respect to cutoff, I don't remember, but clearly there's some anchoring in validated tools that assess these dimensions.
We have a comment here. What happened to vulvar pain syndrome in ICD-11? Have I missed it somewhere?
Which one, vulvodynia?
No, that's in the ICD-11, but vulvar pain syndrome is missing.
Oh, well, vulvodynia and vulvar pain syndrome would basically be synonyms. They are a very specific condition, so they are what the WHO calls below the shoreline. So in the linearization for mortality and morbidity coding, it's not visible. It's just one of the chronic visceral pains. However, when you search, you can even search all the way down to lots of detail in the foundation. And the intention of WHO is to have everything in the foundation. I didn't check it myself, but I think with Virginia, there had been a letter to the editor that we commented on. And I thought it had been implemented, but I didn't check. So the coding tool should identify it. And then if there are synonyms, there's also a way of handling synonyms within the coding system of WHO. And if it's not present, it's a very simple proposal that someone could make and say, there's a synonym missing, and then probably the classification statistical advisory committee, they meet, I think, 4 times a year, put it on the agenda, and at some point in time, they will probably simply say yes, without asking for scientific advice, because it's pretty straightforward.
So we have about 5 minutes left. So there's a question here about neuropathic pain and one about post-surgical pain. So I'll ask those. Neuropathic pain, particularly in diabetes, is sometimes difficult to manage. Have we anything new to say about this in terms of developments, treatment developments?
I think this is a good occasion to remind ourselves that people can have more than one condition. They can have more than one pain. So if someone who, in retrospect, we think might have had a primary pain condition and was erroneously operated on the spine, we have the failed back surgery syndrome that has been in the literature for many decades, and that will be a chronic secondary pain after surgery. Well, depending on how polite you want to be, you might even say the surgeon caused the pain, of course, in the attempt to alleviate pain. And in that case, probably the primary pain condition was not alleviated, so it's still there. And in addition, there might be a chronic post-surgical pain. Why is this important? So for chronic post-surgical pain, scar injections can be helpful. For primary pains, there's not much that you can inject. Yeah, so clearly there could be 2 pain diagnoses in such an example, and they might require elements of 2 sets of treatment.
Okay. Since we've only a few minutes left, I have one question, is that if clinicians or anybody attending today wants to find out more information, is there a certain site that they can go to beyond the ICD, or is there certain publications or guidelines of treatment or anything in the pipeline that people should be looking out for?
First of all, I would recommend June 14 at 12 UTC, Universal Time Coordinated, used to be called Greenwich Time. There's a WHO webinar on pain classification. So that's the next opportunity to ask questions. And the International Association for the Study of Pain has a number of activities leading up to it. The current Global Year Against Pain is about integrated pain services, so it also connects. So there are lots of materials that could be used. If I may, I would take up one question about plasticity to insult. Someone in the chat had addressed this multiple times. My answer is yes. So my personal concept is that plasticity to insults, be they bodily or stress, and a high susceptibility to these insults could actually be what's behind chronic primary pain, where the insults are minimal and trivial, and may also contribute to long-lasting chronic secondary pains, where very often to the same insult, people do not have a chronic pain problem. And the question about central sensitization happens all the time. So it is definitely part in its several levels, what it can be, spinal, brainstem, cortical, also happening in primary pain, but it also happens with each trivial injury for a day. Yeah. If you knock your knee on something, you will have a central sensitization for a day, and hopefully it's gone. So it does not discriminate from something else.
Great.
Sorry that I preempted this.
I just want to inform the attendees as well. Some people were looking for references to some of the papers that you mentioned, so I will collect some references from our speakers today and we can distribute them so everyone will know about the reading.
Yeah.
Jane, can we apply for the WHO webinar? I'm not sure, but I could find out. Do you know?
Cannot yet register. So the day has just been decided 2 weeks ago. The IASP website will advertise it, and WHO will also advertise it. So it will be advertised from 2 sides. And maybe if EFIC wants to pitch in and also advertise that event, some of the material is still being written by Kowisi, who is here, so she can inform all of you. And then I think there are these info flyers that EFIC had produced that could also be promoted to people who attended this meeting here.
Yes, because we're after writing a lay article actually that will be going online today or maybe next week on chronic primary pain that breaks some of this down. There's one last question if somebody wants to answer it. How long maximum should a patient be subscribed to opioids when waiting for an operation? It's different to the topic, but does anyone want to comment before we close?
I refer to the physicians present.
Sorry, I didn't hear the question because I told them I would leave this room now, but I have a second. So if you could repeat the question. Maybe Paul, you can answer it. Yeah.
Well, I was going to say it might also depend on whether it's a primary pain, whether it's secondary pain, whether opioids should have been prescribed in the first place. And arguably the evidence for chronic primary pain opioids is low in any case. So the question would be, what led them to prescribe the opiates before the operation in any case, especially if there's a view that the surgery is somehow going to fix this chronic primary pain, in which case that would be a very dangerous road to go down, I would suggest. Yeah. But I feel like there's a lot of nuances to that question.
Yeah, opiates are a difficult topic. So some people actually benefit for a long period of time, but that number is very, very small. So generally speaking, whenever someone is put on opiates, there must be an exit strategy. I think. And so when waiting for an operation, it relates to the question of wait times. They shouldn't be that long. So it's difficult. But clearly,
so we can...
for opiates, the dosage of opiates should always be questioned, and there are certain strategies that have been published and that maybe people know, where I think there had been a cultural difference between the US and Europe, because we have much, much less of a problem in Europe than the catastrophes that they had in the United States. I think it deals with education, but also with social networks. And we have to be aware in Europe that we maintain the situation and keep improving it, and not fall into the traps that some people in the US fell into. Yeah.
Okay. Thank you to everyone that attended this webinar, and thank you to Bea, Rolf-Detlef, and Paul. That was excellent. Loads of questions, very interactive. And I'll be in touch with references to the work that was mentioned today.
Thank you very much to the audience. This was a very lively audience. I enjoy much more when the audience is lively. Thank you very much.
Thank you very much.
Thank you. Okay, everybody have a good weekend. Thank you.
Bye.